If you're over 60, there is something you need to know about some of the most common pills people take every day. Not because every one of them is wrong, not because your doctor made a mistake, but because after 60, the way your body handles medication changes and the margin for error gets smaller. A pill that seemed harmless at 45 can behave very differently at 65. A medication you tolerated for years can start pushing blood pressure higher, affecting heart rhythm, increasing clotting risk, triggering bleeding, or placing added strain on blood vessels that are already less resilient than they used to be. And that is exactly why some heart attacks and strokes seem to come out of nowhere. The risk was building quietly in the background. I'm Dr. Clara Hoffman, and in this video, I want to walk you through 5 common medication categories that can raise cardiovascular risk after 60, especially when they are used too often, used in the wrong context, or mixed with the wrong combination of other drugs. And I want to be very clear before we begin. I am not telling you to stop taking your medication. I am not practicing medicine through a video. What I am doing is giving you the conversation many patients never get during a rushed appointment, the age-specific conversation. Because what changes after 60 is not just your age, it is your physiology. Your kidneys may clear drugs more slowly, your blood pressure regulation becomes less forgiving, your arteries are less flexible, your heart has less reserve, and the chance that you are taking multiple medications at the same time goes up dramatically. That combination changes everything. I'm going to give you 5 medication categories that deserve a second look if you are over 60, and number 3 is the one that surprises people most because it is not just one pill. It is what happens when 2 very common pills meet each other. Let's start with the one many people think is harmless because you can buy it without a prescription. Number 1, NSAID pain relievers, Ibuprofen, Naproxen, diclofenac. These are some of the most commonly used pain pills in the world. People take them for arthritis, knee pain, back pain, headaches, shoulder pain, and everyday aches that become more common with age. Here's the problem. After 60, these drugs can do much more than irritate the stomach. They can raise blood pressure, they can worsen kidney function, they can make fluid retention worse, and they are associated with increased risk of heart attack and stroke, especially when used regularly rather than occasionally. That is what makes them deceptive. A person may think, it's just ibuprofen. I've taken it for years. But the cardiovascular system at 68 is not the same as the cardiovascular system at 42. And what often happens is not one dramatic event at the start. It is gradual pressure on the body. The blood pressure creeps up, the kidneys become less efficient, the heart works harder, then one day the person ends up with chest pain, shortness of breath, uncontrolled blood pressure, or a hospitalization nobody connected to the pain pill in the medicine cabinet. If you take a pain reliever more than occasionally, the question to ask your doctor is this: is this the safest pain option for someone my age, blood pressure, kidneys, and heart history? That question matters more than most people realize. Now, number 2 is one of the most overlooked because people do not think of it as a heart risk medication at all. Number 2, oral decongestants. I'm talking about pills used for cold and sinus symptoms, especially products that contain pseudoephedrine and similar stimulatory ingredients. Why does this matter after 60? Because these pills can tighten blood vessels, they can raise blood pressure, they can increase heart rate. And in people who already have hypertension, coronary artery disease, atrial fibrillation, or vascular disease, that extra cardiovascular stress is not always trivial. This is where people get caught off guard. They are not taking a heart medicine. They are taking a cold medicine. But the body does not care what label was on the box. It only responds to the physiological effect. If you are over 60 and you already have high blood pressure, a history of palpitations, prior stroke, coronary disease, or you are taking multiple heart medications, an oral decongestant may not be as innocent as it looks on the pharmacy shelf. And because people tend to self-medicate cold symptoms, many never think to mention it to their physician at all. That is the hidden risk. The question to ask is, given my blood pressure and heart history, Is there a safer option for congestion than an oral decongestant? Now we come to number 3, and this is the one that consistently catches people by surprise, because number 3 is not one drug. It is one of the most dangerous combinations older adults accidentally create for themselves. Number 3, blood thinners mixed with common pain pills. If you are taking a blood thinner such as apixaban, rivaroxaban, dabigatran, or warfarin, and then you reach for ibuprofen or naproxen for pain, that combination can become dangerous fast. Most people understand that a blood thinner increases bleeding risk. What many do not understand is how dramatically that risk changes when an NSAID is added, because now you are hitting the body from 2 directions at once. The anticoagulant reduces clotting. The NSAID can irritate the stomach, affect platelets, and increase the chance of internal bleeding. And after 60, that can mean gastrointestinal bleeding, anemia, hospitalization, or even bleeding inside the head. This is the medication trap I want older adults to remember. The more prescriptions you take, the more dangerous just one over-the-counter pill becomes. People often think the real risk comes from prescription drugs, but sometimes the serious event begins with the pill they bought themselves. So if you are on any blood thinner, the question is simple and non-negotiable. Which pain medications are actually safe for me, and which ones should I never take without approval? That question can prevent a catastrophe. Number 4 is a class of medications many people are prescribed repeatedly over the years for inflammation, joint flare-ups, skin conditions, lung problems, or autoimmune issues. Number 4, oral steroids. Prednisone is the name many people know best. Now let me be careful here. Steroids can be extremely useful. Sometimes they are absolutely necessary. Sometimes they are the right treatment. But older adults are often underinformed about what repeated or prolonged steroid use can do to cardiovascular health. Steroids can raise blood pressure. They can raise blood sugar. They can increase fluid retention. They can worsen weight gain and metabolic strain. And over time, those effects can translate into a higher burden on the heart and blood vessels. This is especially important in people who already have diabetes, borderline blood pressure, swelling, heart failure risk, or a long medication list. What makes steroids tricky is that they often make people feel better quickly. Pain improves, breathing improves, inflammation settles down, so the short-term relief can distract from the long-term cost. And that is exactly why this category deserves a more careful conversation after 60 than most people ever receive. The right question to ask is, what is the shortest effective duration? What are the cardiovascular trade-offs in my case? And is there a safer long-term alternative if I keep needing steroids? That is the question that turns casual repeat prescribing into smarter prescribing. Now, number 5 is especially important for women over 60, and it is one of the clearest examples of how root, age, and timing matter in medicine. Number 5, oral estrogen-based hormone therapy pills. I want to emphasize the word oral because this is where many people miss the nuance. When hormone therapy is discussed casually, it is often talked about as if all forms are the same. They are not. Oral estrogen or oral estrogen progestin therapy can carry a higher risk of blood clots and ischemic stroke, and that conversation matters even more once a woman is older, further from menopause, or already has cardiovascular risk factors. Again, this does not mean every woman should stop therapy. It does not mean no one should use hormones. It does mean the risk conversation must become more specific after 60. Not just, am I taking hormones? But, why am I taking them? What form am I taking? Is oral still the best route for me? Has my stroke risk been reviewed recently? That is the level of detail that protects patients. Because what often happens in real life is that a prescription gets continued, the years pass, and nobody pauses to ask whether the current version of the treatment still matches the current version of the patient. And that is the larger message of this entire video. The body changes, the risk changes. But medication lists often keep moving forward as if nothing changed. That is how people end up taking a drug that once made sense in a body where the math is no longer the same. So let me be completely clear as we finish. I am not telling you that these medications are bad. I am not telling you to stop anything on your own. I am telling you that if you are over 60, you deserve a medication review that is specific to your age, your cardiovascular history, your kidneys, your blood pressure, and the medications you combine without even thinking about it. And if you want to protect yourself, here are the 5 questions to carry into your next appointment. What is this medication doing for me right now? What are the harder stroke risks at my age? Is this still the safest option for my current health profile? Are there interactions with my over-the-counter medicines or supplements? And when was my entire medication list last reviewed as one complete system instead of as separate prescriptions? Those 5 questions can change the trajectory of someone's health. If this was helpful, share it with someone over 60 who takes daily medication, because the most dangerous medication risk is often the one a person never knew to ask about. And if you want more videos like this, stay with me. I'm Dr. Clara Hoffman, and I'll see you in the next one.